Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. Today we have what I think is a very interesting topic. Is cannabidiol, CBD, useful for the treatment of opioid use disorder, or OUD? And with us today is certainly an expert in the field, Dr. Joji Suzuki from Harvard Medical School. How are you today, Joji?
I'm very well. Thank you for the invitation. I'm looking forward to this conversation.
Me as well. Well, let's just start out with the fact that, as you and I were talking about a minute ago, there has been quite a bit of research on CBD in particular and cannabinoids more widely on various psychiatric conditions. But you're focusing more specifically on OUD. Can you tell me about that?
Sure. So I'm an addiction psychiatrist. And so most of my career has spent providing direct patient care for substance use disorders with a particular emphasis on both opioid use disorder and alcohol use disorder. And most of my clinical work has been done in specialty addiction settings, but also a huge chunk of my work has been done in the hospital consultation, inpatient consultation setting in acute care, emergency room, hospital, that sort of thing. But I've done, a full spectrum of, treatments, and I direct our division that oversees the whole range of services. And so I always tell people that I finished medical school in 2002, which is the year that buprenorphine became available. And it's really, so I've been able to see the entire arc of the opioid crisis from the early days, as well as the treatment, the gold standard treatment for OUD is buprenorphine. And so I've had the, luxury of kind of watching the whole trajectory of both the opioid crisis and the treatment approaches to it. And in the last 5 years or so, I've really transitioned towards really dedicating most of my time to research, partly driven by the fact that, as a clinician, I feel really frustrated that, we're well into the second, third decade of the opioid crisis, yet innovation when it comes to pharmacotherapy for OUD really hasn't happened. No. So the way we practice buprenorphine treatment for OUD really hasn't changed since 20-something years ago. I mean, of course, there's been innovation in the delivery approaches.
The formulation.
Yeah, the formulation. We have now, many more different formulations, but besides that, the actual mechanics of treating OUD hasn't changed a whole lot. I mean, of course, we've made a lot of changes in some ways, like we provide it in more settings and we have innovative induction strategies to accommodate fentanyl, so it's, changed at the edges, but fundamentally the way we approach treatment for OUD is largely the same. And so I've been really, looking towards identifying novel therapies, novel approaches that are more than just additional buprenorphine formulations.
Right. So you're trying not to hit the opioid receptor if you can help it.
That is certainly the other thing. And, when you think about medical
at
treatment,
least not directly.
Right. But when you think about pharmacotherapies for all kinds of chronic illnesses, the norm for most conditions is to begin targeting multiple mechanisms of action. So whether it's diabetes, hypertension, cancer, asthma, you're never satisfied with just one mechanism. So, if it's hypertension, you don't just push diuretics. And if it doesn't work, you think, okay, let's try another diuretic and let's go up with a dose. And if that doesn't work, let's try another diuretic. I mean, at some point you realize pretty quickly that let's try other approaches. When it comes to OUD, that's really not been the case. We do buprenorphine. If it doesn't work, we recommend methadone. If it doesn't work, we use naltrexone. And that's about it.
Well, I was going to ask about naltrexone. Again, it's still an opioid manipulation.
Yeah, technically, pharmacologically, it is an opioid. It's an opioid antagonist. People get confused because, it's not an opioid, right? But it is an opioid. It's just that it has, provides no activity, but it's still an opioid, So it's really all the main options are opioids and agonist, antagonist, and that's it. And now, of course, I would strongly argue that those agonist therapies are quite effective. But the reality is we need to do better. And as the statistics around overdose deaths, et cetera, are clearly indicating, we're barely keeping up if, in fact, we're falling behind.
Yeah, there's still certainly quite a bit of risk, I would say, even if there's decent efficacy.
Correct. And, the average retention and care for buprenorphine hovers around 50% at six months. And that decreases to about 25% at 1 year, meaning,
oh my goodness,
even though it's an effective treatment, by 1 year into treatment, 3/4 have left treatment. And for many of them, they've relapsed. Mm-hmm. And so even though compared to other chronic diseases, this is actually would be considered pretty good outcomes. Overall, we need to do better. And so one of the main research, approaches, research sort of, efforts that we focus on is once you have somebody on effective therapies like buprenorphine or methadone, what else are we supposed to do if they're not fully responding? If they're responding, awesome. But a huge chunk of the individuals are not fully responding. They continue to, be at risk for relapse, treatment discontinuation. And there are many reasons too. It's not just a pharmacologic issue, but
of course,
if it is a pharmacologic issue, excuse me, how do we enhance the, efficacy of effective therapies? And additionally, of course, if somebody's not appropriate or is not willing to take buprenorphine or methadone, what else can we be doing? And so in that context, we look at all kinds of things, but cannabinoids represent one potential, avenue.
Yeah.
And
tell me how you came to cannabinoids specifically.
Sure. So in the context of liberalizing access to cannabis and cannabinoids, and, things have changed dramatically in the last decade, as we all know, and which is, I think it's a good thing, criminal sanctions to control drug use has really never been effective, and it's been a complete disaster.
That's right.
And so
that's true.
I think liberalizing access to cannabis and cannabinoids, I think is the right policy, approach. But in that context, there was a lot of discussion and population level data to suggest that cannabis may in fact be helpful in addressing opioids or reducing the use of prescription opioids for chronic pain, or that it could be a direct, treatment for chronic pain. It can reduce overdoses, so a lot of this sort of narrative about cannabis access will lead to improvement in opioid related outcomes, but largely based on population level, data.
Right.
And
do we have preclinical data?
Yes,
or mechanistic data?
Correct. So preclinical data would suggest that, cannabis or cannabinoids can, and when you look at animal models, there's a couple of basic paradigms that are utilized. One is self-administration. You train a, mouse to take a particular drug and you give this particular intervention and see what happens. Do they use more? Do they use less? Does it change? And cannabinoids definitely have been shown to reduce self-administration of all kinds of substances. And then the other is condition place preference or condition place aversion, or CPP, CPA. You train the animal to, prefer a particular location as it's a condition reinforcement. So the mouse begins to, correlate the location with something rewarding or something, not rewarding or aversive. So if it's rewarding, that mouse will prefer that. If it's aversive, it won't. And so these cannabinoids have been demonstrated to increase condition place preference. So, or the opposite. So there are many approaches that have been utilized to try to examine, whether animals, respond to these, cannabinoids or others in ways that are maybe beneficial. And the general, finding is that it does. And the major one is this called reinstatement. So you train a mouse to get basically quote unquote addicted to a substance. And then you force a period of abstinence, and then you reintroduce them to whether triggers or the drug itself, and to see if the particular intervention will attenuate that to some degree. And they've been able to demonstrate that cannabidiol specifically reduces or attenuates the cue-induced reinstatement to heroin in mouse models. And so all of these different sort of, animal models have pointed in the direction to suggest that cannabinoids may help reduce substance use. But of course, there's a big gulf between animal studies and human studies.
Of course.
It's a good place to start, but that's really never enough to justify, broad application in clinical populations.
Sure. Before we get into the clinical data, what about the neurobiology? I mean, cannabinoid receptors are ubiquitous throughout the brain. Of course, they are highly concentrated in the limbic system, the nucleus accumbens area, and there's a lot of crosstalk with the dopamine system. But am I on the right track? What is the hypothesized neurobiologic mechanism here?
In terms of the potential therapeutic efficacy, is that what you're?
Yes. Yes, for opioid use disorder.
Right, because there's two directions you can think about. One is that cannabinoids as a potential substance of misuse and how it impacts the reward system, et cetera. The other is that it could potentially attenuate opioid-related sort of outcomes like pain or cravings, et cetera. And so obviously, CB1 receptor agonists have misuse potential. And because activating
THC,
correct activation or the agonist effects on CB1 definitely appears to, activate what, sometimes called the final common pathway, the mesolimbic reward pathway. And
that's
maybe
the motivation.
Correct. It's rewarding, therefore it could be misused. So THC clearly appears to have that. But cannabidiol, as we know, and I'm assuming you and the listeners are quite aware, it is not a CB1 or CB2 agonist. It may be an antagonist. In fact, it may be an inverse agonist, but certainly doesn't have appreciable agonism at the CB1 receptor. As far as I know, the science of the mechanism is still not really figured out with cannabidiol. But if anything, it may be like a FAAH inhibitor, a weak FAAH inhibitor.
Oh, sure. Right. Yeah, that's the enzyme that, of course, breaks down THC or
anandamide.
Anandamide specifically, the endogenous ligand, exactly.
Correct.
Got it.
So CBD may, in fact, enhance the endocannabinoid system indirectly through a weak inhibition of the FAAH enzyme.
So it's analogous to monoamine oxidase inhibition, roughly, I realize.
Yeah, it's an weaker, indirect mechanism. Now, that's the hypothesized, pathway.
Okay.
But of course, as we know, CBD is pretty complicated. It's a very, as they call it, promiscuous sort of, a ligand. And it's not clear, what it's really doing. But it does seem to impact the endocannabinoid system in some indirect fashion, but not directly through the CB1 receptor.
Does it bind to CB2?
I believe so. And but
it might have some activity, CB2.
But I don't believe that it's an agonist.
Okay, right. Like you said. There are drugs, parenthetically, in development that are FAAH inhibitors, as you may know, that are being looked at for a variety of indications. So that's a fascinating mechanism. All right.
Right.
Well, let's move on to your clinical work. Let's talk about what you have found so far.
So because of the population level data, again, there's this narrative about cannabis or cannabinoids potentially being helpful as therapeutic in interventions for OUD. But, one of my mentors, Roger Weiss, and I published a commentary to say, look, these population level studies are helpful, but they're absolutely not, causation. You cannot attribute causation.
Right.
It's correlational and all kinds of things can cause that. And so until we have more rigorous studies, we should not be promoting cannabis or cannabinoids as proven therapeutics for OUD. That said, there were several emerging studies to point in the direction that they may in fact be. There are 2 randomized trials to demonstrate that THC, in fact, the synthetic version dronabinol, actually will attenuate opioid withdrawal. So there are 2 studies that have demonstrated in a double-blind, trial, THC versus placebo. THC significantly reduces opioid withdrawal severity compared to placebo. And so there's one clear signal that a constituent of cannabis may in fact help with opioid withdrawal. In fact, anecdotally, people have told me and others have reported that cannabis can help with opioid withdrawal. And so that's one aspect of it. However, as far as we know, THC has not been demonstrated to, enhance retention and care or reduce cravings or anything related to other OUD outcomes, except for a trial that was conducted by Dr. Yasmin Hurd, did a really elegant study, a double-blind crossover study of cannabidiol versus placebo, 2 different doses of CBD actually, in individuals with OUD who are completely abstinent from, either buprenorphine or methadone. And so what she was able to demonstrate is that 3 days of cannabidiol, 400 milligrams or 800 milligrams, significantly reduced cue-induced craving up to, I believe it was maybe up to like 7 days after 3 days of dosing.
Only 3 days. Okay.
I'm trying to remember the exact the time frame, but it persisted beyond the initial, dosing. And this was done in a pretty rigorous fashion, double blind, and 2 different doses compared to placebo. And not just cue-induced cravings, but also, I believe, anxiety as well. And this was the first indication in the first double-blind placebo-controlled trial of cannabidiol, demonstrating that there was a significant impact on something we would consider critically important in thinking about risk for relapse, specifically cue-induced craving. And so,
so that might be helpful then in maintaining abstinence, is what we're saying here. Maybe the implication.
Correct. And studies done over the last decade or two have shown pretty convincingly that cue-induced craving is a major, not the only one, but a major sort of risk factor for relapse. So, what cue-induced craving simply means is that, when you're in treatment, when you're exposed to reminders, and this is a very common saying in AA or NA meetings, people, places, and things, people that remind you of the, drug use, or places or things, paraphernalia, etc. All these things can actually trigger your brain to crave, to want, to seek. And this happens despite being highly motivated for treatment. And this happens even if you're been abstinent for a long time. It's simply drug memories that are triggering these reminders are triggers. And so once you're triggered, that can actually evoke this very strong subjective desire to use. And that desire to use, or cravings, can be pretty powerful. And then cravings that go unsatisfied can be quite distressing. It's like no different than if you're hungry. If you're hungry and you can't eat, it's distressing. That's the whole point of actual hunger, is that it's to get you off the couch and to find something to eat. And it's no different with drug cravings. If you're craving, tolerating that can be difficult. And so when the cravings are strong, it's really hard to resist. And so cue-induced craving is considered a major mechanism by which relapses occur.
Yeah.
And what's really troubling, from a clinical perspective, is that this type of, reactivity can occur below your level of awareness. So you may subjectively start wanting or seeking or craving without really even knowing why. Okay. All you know is that I want this thing to go away. And that can be a powerful, sort of a antecedent to a relapse event.
So it sounds like some of this is moving towards something pleasurable, but it's also trying to attenuate something negative. Am I conceptualizing that correctly? You're trying to get rid of this uncomfortable feeling.
Yeah. And that's one of the...
bit of both.
Correct. Negative reinforcement is considered a very important mechanism to sustain a particular behavior. In this case, removing this distressing feeling, cravings, can be a powerful motivator. Now, there are other negative reinforcers. For example, negative mood. If you're sad, had a bad day, irritated, and things that can take that away can actually be another, reinforcer as well. But cravings on its own can become the reinforcer. That, removing that can be the reinforcer.
Yeah, of course. That makes sense. I think a lot of our audience may think of this as someone's just trying to get high or trying to get a high, but of course, you're explaining how much more complicated it is than that, and that's fascinating.
It is. And that's why, with addiction, that's why from the outside it appears very irrational. If you're someone who wants to be in treatment, wants to abstain, and is actually telling you that over time, the degree to which they experience pleasure from the particular drug has decreased substantially. And that's called tolerance, so you're constantly, people talk about how you're forever chasing that first time you ever used because that was like the best experience ever. And since then, it's been a downhill ever since. And you can never kind of reclaim that. But so the pleasure you experience has been in decline ever since. And by the time people seek treatment, in fact, many will say, look, I just used to feel normal. Yeah, I feel high, but it's nowhere near what I used to experience. And, I just used to, I don't feel awful. So this negative reinforcement aspect comes even a stronger motivator than the positive reinforcement, which is how it usually starts. I take a drug because it feels good, that makes sense, but over time it gets replaced by, I just don't want to feel awful anymore.
Right. And of course there probably are genetic predispositions to this and other things, obviously.
Oh, absolutely.
Too.
Yeah.
I would think. Yeah. Yeah. Because, a lot of people experiment or try drugs, but they don't get hooked, if you will. So obviously there's many factors.
Right. And that's the, unfortunately or not, majority of people who use drugs never get addicted. The majority don't. And, what is sometimes called the conditional risk of addiction, the proportion of people who end up being addicted For even the most addictive, quote unquote, addictive drugs, it's probably never more than 20%, like cigarettes.
Okay.
Most people who try cigarettes, thankfully, don't get addicted. But those who do, it can be pretty tough. And for opioids too, we think the conditional risk is in that ballpark. Maybe 20% ish or so. The most people who are exposed to opioids never get addicted. But so, like you say, there are other factors that contribute to the risk. Genetic, early life experiences, peer pressure, mental health, many things.
Yes. Well, mental health I was going to bring up, of course, the very strong relationship here with the various psychiatric illnesses we work with. We know, of course, that substance abuse is associated with virtually the whole DSM, I like to say.
Right.
All the mood disorders, schizophrenia, anxiety disorders, PTSD.
Yeah, absolutely. So the dronabinol or the THC attenuating opioid withdrawal, and then the Yasmin-Hertz CBD study. So all kind of, coalesced for me at a time when I was making this transition towards research. And I think this is maybe the third year of my K award, which is an NIH Career Development Award to get mentor training and research. And so initially I was kind of maybe thinking about focusing on a trial of recovery coaches because that's a big part of my research as well. But when Yasmin-Hertz study came out and I realized, this is a potentially really interesting adjunctive treatment to buprenorphine. But what I found problematic to that study is that she was enrolling individuals who were not taking any buprenorphine or methadone, which is fine.
Right.
But from a clinical perspective, we would always, initially really encourage buprenorphine or methadone. And that's a population that I really, care a lot about as well. Of course, if someone doesn't want those medications, I get it. But, we also need ways to improve treatment, the outcomes of those already on these effective therapies. And so I thought, that was a really nice study. Let's replicate that, but among individuals who are already on buprenorphine to see if we can demonstrate similar reductions in cue reactivity, even if you're on buprenorphine. And that remained an empirical question we didn't know.
Has buprenorphine been shown to decrease cue-induced craving?
That's an excellent question. And that's only been demonstrated more robustly in the methadone population, but not in a longitudinal study, but cross-sectionally, meaning you take a bunch of people early in treatment, take a bunch of people late in treatment, and compare their reactivity, whether neuroimaging or self-report. And when you do studies like that, you're able to demonstrate that, people who have been in treatment longer generally report, less reactivity than those who are early in treatment. But as far as I know, and this is pretty shocking, that nobody's ever done a longitudinal study, take the same group of individuals over time and measure how their cue reactivity changes over time and how that correlates with their risk of relapse, et cetera. And so it's better described in the methadone population, less so in the buprenorphine. And as far as I know, no actual longitudinal studies to prove, that reactivity decreases over time or that buprenorphine itself has a significant impact on reactivity. Part of the challenge is that you really can't find, patients who are opioid free with the OUD. It's hard to do a study like that because you're either actively using or you're on medication treatment. And if you're not, you're likely in a much more stable place, so that you don't need medications. So it's actually hard to do research on OUD patients who are still in the midst of their addiction, but not using any opiates at all.
Not using.
It's actually hard.
So I was just thinking from a research point of view, the confounding effect of the buprenorphine itself. But if you're looking at adjunctive, you're looking for an additional effect beyond that. So if there is one,
And, based on the available, research and clinical experience, it's very clear that even if you're on buprenorphine or methadone, patients remain at risk for relapse. So we know this.
As you said.
Correct.
Earlier.
And so we knew that they're likely, we can demonstrate, that these individuals can remain reactive to cues. And in fact, that's where we did them.
All right. So let's get into the two studies you did.
So the first was a sort of a, pilot. We were able to, we sought out a small, amount of funding, like a local institutional fund to do a small study. And basically what we did is a open label, single arm pilot. Individuals would receive 3 days of 600 milligrams of cannabidiol. In this case, we only use Epidiolex, which is the FDA approved, CBD isolate, and 600 milligrams is chosen based on, Dr. Hurd's study. We just took the average between 400 and 800. And many trials use in that range. So it's typically in that range, 400 to 800. So we thought 600 is a good place to start.
Just for comparison, do you know the therapeutic dose for the indication that it has, which is a form of epilepsy, I believe?
That's a good question. I don't treat epilepsy and I don't treat kids. And so I actually don't know. That's a great question.
Yeah. I'm just curious.
It's like, but I don't know. It may be comparable.
Yeah.
I actually don't know. I should look. I
but
should know
commercially, that's okay. Commercially, it comes in a certain size pill, I would think.
Interestingly, Epidiolex only comes in a liquid oil suspension, and that creates its own issues. So it's 100 milligrams per milliliter solution.
Okay.
And you get a little tiny dropper to administer it. And it doesn't come in a pill for the Epidiolex. Now, there are proprietary formulations that people do research with, but I wish those were more widely available. When you look at dispensaries, for example, the dose ranges are significantly lower. 10 milligrams, 15 milligrams, 20 milligrams. So you can't ask people to take, 30 tablets, So for research purposes, we end up using the Epidiolex. And of course, it's FDA approved and, GMP, all that.
That's right. So that's an important point. These are much higher doses than I could get from just going to, a store or a dispensary, as you were saying.
Correct.
Many places that advertise CBD, you see it everywhere.
Right. I tell patients that I think that 10 milligrams, 15 milligrams is potentially a homeopathic dose. And now if you find it beneficial, fine. I don't have any issues at all. Right. Of course. But if you're hoping to replicate what we're seeing in clinical trials, I suspect that 10, 15 milligrams just ain't going to cut it.
Yeah, ain't going to cut it. All right. So back to your study. I'm sorry. You said 600 milligrams.
So 3 days of it. So basically we replicated Dr. Hurd's study of 3 days of 600 milligrams per day. And we did pre-post design. We did a bunch of measures before and then a bunch of measures afterwards. And so predominantly looking at things like mood, anxiety, pain, and then obviously specifically cue reactivity before and after.
And I'm sorry, what was the time frame? What was your endpoint? It was 3 days of treatment. And did you do your endpoint then or later?
Correct. And so it was either Monday, Thursday, or Tuesday, Friday was our basic design. So they showed up on Monday. They take their first dose with us. So we do the baseline measures. We administer the first 600 milligrams. And then they took 2 doses home. So Tuesday and Wednesday, they took the dose. And on Thursday, came back to repeat the same tests, basically. So
day 4, essentially. Yeah.
Correct. Day 4.
Very good. Okay.
And this happened right during COVID. So it kind of limited our enrollment, but we were able to run 5 individuals. And it was just, we want to go through the motions. This is the first human laboratory-based study that I've ever conducted. Most of the work that I've done is health services type research or clinical trials, so this is a laboratory sort of a based investigation. And so, so we ran 5 individuals and we were able to demonstrate that there was indeed a reduction in cue reactivity from baseline to follow-up. Now the magnitude wasn't that great and the reactivity itself wasn't particularly strong, but people were, and the basic way that the cue reactivity paradigm works is you have them sit in front of a computer and they look at a series of images. And in one condition, they're looking at images that are like, needles and powder and a spoon and a tourniquet and all the paraphernalia and then people injecting. And the neutral cues are basically thematically matched, but more benign objects. So instead of a needle, it's a pencil. That sort of thing. And so we try to match it so that thematically they're similar in nature. And you sit there, you have to stare at these images for a while, and then you rate how your cravings, and you basically repeat with the neutral images, and you compare them. And so the difference between the neutral reactivity and the drug-related reactivity is your cue reactivity. And we demonstrated that when this, after 3 days of CBD, the degree of reactivity decreased over time. Now, with a single arm design, you can't be too sure. Is this simply habituation, just a, regression to the mean? And, there could be many reasons for why it could happen. So, but at least this was a sufficient preliminary data to argue for something more rigorous in a double-blind study.
Right. It's a great pilot study.
Yeah. And so that's exactly what we did. We took this data and said, we sought out additional funding to conduct basically a proof of concept pilot RCT. But in this time, we designed a crossover study, and crossover permits a smaller sample size. And so we had to sort of compromise here. Ideally, we would have replicated the 3-day dosing and do a parallel arm RCT, meaning you take a bunch of people, they take the CBD for 3 days, and we do a pre-post design. And then we take another bunch of group of people who receive placebo and, do the same thing, and it's randomized so nobody knows. But in that kind of a design, you need more people. And the amount of funding we got, we only had sufficient funding to run 10 individuals. So we chose a crossover design where each person gets placebo or CBD, but we could only do one dose. So they came to the laboratory and they went to the initial testing and to get baseline measures. Then they received one dose of CBD or placebo in double-blind fashion. And then, go through the, cue-reactivity, and then wait 1 week. They come back a week later for a washout, and then repeat the same procedures. And they receive, either the CBD or placebo, the opposite. This is called the crossover because each person acts as their own control, and you can reduce the total sample size. But then the problem here, in retrospect, of course, we know more, that design kind of backfired because, in a way, like how can 1 day versus 3 days may not seem like a lot, but maybe, in retrospect, that felt like that could have been a problem. But still, that's what we did. Yeah. N of 10, crossover, randomized trial, single dose CBD versus placebo, and basically looking at the same neurocognitive processes like cue activity. But we also added things like decision-making, distress tolerance, stress reactivity.
Interesting.
But those are secondary exploratory kind of tests. And our primary outcome still remained, does this impact cue reactivity? And we did 2 types of tests, the standard cue reactivity paradigm that we use, but also what's called a visual probe task, which examines what's called attentional bias. And that's getting to a more of a sort of a deeper level, because as I mentioned earlier, when you're exposed to cues, that triggers this subjective feeling of cravings. Wanting, the seeking. But what we suspect is that even before when the desire for the drug is so strong that you can subjectively experience it, there's actually, your brain is already primed to seek out these, substances even without your conscious awareness. And so there's a test called the visual probe task that begins to, examine this neural level responses that's not contingent on subjective awareness. And I can explain this sort of how the test works, but basically the person sits in front of a computer and 2 images will flash on the screen. Sometimes it's the drug and drug, sometimes it's drug and neutral, but different images show up. Basically either drug images or neutral images. And in one of the conditions, the images flash very quickly, 200 milliseconds. So by the time your eyeballs, fix their gaze on the image is gone, meaning you cannot shift the gaze. So by the time there's enough time to look at one image, but not both. And when the image disappears, a probe appears on one of the images, behind one of the images. And yet the subject has to press the button, is a probe on the left or the right side. And the basic idea is if your eyeball moved towards the drug, and the probe appeared on that, then you can more quickly press that button. If the probe appeared on the neutral, then it would take you longer to recognize that it was on the other side. So you can begin to calculate, like how quickly are you, well, of course it's contingent, of course, on, how quickly you can press and that sort of thing. But it gives you a sense of, is your brain primed to, before even you're consciously aware, directing your gaze towards a particular stimuli or not. And this has been done in previous studies with cannabidiol to demonstrate that there's attentional bias to drug-related images for tobacco.
I see.
So,
wow, that's fascinating.
And this attentional bias is considered one of the preconditions for this concept of cue reactivity. Because as your attention gets drawn towards drug-related stimuli, that actually further increases your attentional bias towards that, which then further, that eventually leads to the conscious awareness that, oh, I like that thing. I want to get some of that.
Right.
And so we did 10 individuals, double-blind crossover design, one dose of 600 milligrams of CBD versus placebo. And we were able to demonstrate that just like in our pilot study, there was a significant reduction in cue reactivity from CBD compared to placebo, as well as potential bias away from the drugs for the CBD condition, and the opposite for the placebo, which is that there was a greater attentional bias towards the drug-related cues. So everything was moving in the right direction, meaning if you took CBD, you were less likely to have attentional bias towards the drug, and you had reduced cue-induced cravings when exposed to triggers. But we were not able to demonstrate any significant difference in all the other secondary outcomes I mentioned, things like distress tolerance, decision-making, delayed discount, stress reactivity, etc. And, again, in retrospect, in a single dose of CBD alone is probably not going to do a whole lot. But so in that sense, it's pretty impressive that we were able to show that there's at least, some, change in cue reactivity.
Well, I completely agree. I think it's remarkable, just the one dose. And, I'm wondering if those secondary outcomes being a little more complicated might require longer term treatment. And so I'm wondering even what would a week of treatment look like? 3 days even seems a little short, and that gets me into the next. Well, first of all, congratulations. That's remarkable. It is a very remarkable finding. How about the safety and tolerability? I'm sure it was pretty well tolerated, I would think.
Yeah, for the entire, both the pilot and the randomized trial, we had one individual who reported some mild sedation, but otherwise no other adverse effects. People tolerated it, and that's true for all the CBD studies so far. It's generally well tolerated, and not a whole lot of adverse events reported, which is nice.
Yeah, it is nice. CBD is generally not very psychoactive, so you don't necessarily see a lot of psychiatric related side effects.
Correct. Yeah. If anything, it's been potentially has antidepressant, anti-anxiety, sleep, antipsychotic, so it potentially has, broad indications, but.
Well, you have me wondering now, though, about the dose and the purity of the CBD that's used in these various studies, because most of the studies with any form of cannabinoid have been pretty disappointing from a psychiatric point of view.
Yeah, I think for CBD, there's a randomized trial demonstrating that it reduces social anxiety, right? And so I think for anxiety, definitely, I feel like there's a strongest signal that cannabidiol may play a big role.
You're right. That's the one area that there has been some positive studies. But again, dose and duration is always an important question in any trial with any pharmaceutical drug.
Exactly. And so, I like the fact that CBD is non-psychoactive, like you say. It's not addictive, right? So the risk is pretty minimal. It's well tolerated, and patients really like it. That's the thing, they're willing to go to the dispensary and purchase this. They seem to really find it helpful. Whether it's mostly placebo, I don't really know. Again, at these doses that the gummies at the dispensary provide, it's pretty minimal, but, patients are well accepting of this. So I think more research is urgently needed.
Right. So clearly the next steps are going to be more studies, larger studies, of course, longer duration of treatment, as you mentioned. But ultimately, Epidiolex, as you said, is available. I mean, we could technically prescribe it, I suppose, to people.
Correct. However,
cost would be an issue.
Cost is an issue. Insurance will not cover off-label prescribing.
Right.
And I tried.
Right.
And my patient came back and said, I was told it'll cost $1,000 a month. So we said, that's not going to work.
Yeah, no. Well, I can imagine, though, going forward with registration quality studies and going for the indication if your future studies pan out.
We'll see. There are a number of trials now ongoing for cannabidiol for OUD. And Dr. Hurd is doing her own, and other companies are, and investigator groups are doing it. There has been some disappointing, news from the alcohol stuff. We're not sure if it's actually helpful for the alcohol, but there are positive reports for tobacco, like I mentioned. Actually, it turns out to be one of the few pharmacotherapies that has been demonstrated to reduce cannabis use in a randomized trial. So CBD has been shown to reduce cannabis use. Again, we're talking about higher doses, 400, 600, 800. And so it's mixed. For some substances, it may be more helpful than others. But of course, for me, I'm really focused on the opioid population. We did approach the NIH to see if they'd be, willing to fund trials. But by the time that we finished our proposals, they had already funded a whole group of studies. So they felt like until those studies are done, they're probably not going to, fund additional studies. Right. So we're waiting to find out, we're eagerly waiting to see what these other trials will show. I hope that they find that it's effective as an adjunct. Yeah. And so we're waiting to see. The direction that I'm actually particularly interested is because of this anti-anxiety property of CBD, does it have any role in treating anxiety itself, A, but B, the world that I live in is in addiction. And one of the addiction issues that is also neglected is benzodiazepines. And one idea would be, could CBD help get people off of benzos?
Yes. Wow, that is interesting.
So we're sort of thinking about what that study could look like, and could we try to get funding for it? And, as you know, like there's not a whole lot we can recommend for getting people off benzos. It's a huge struggle.
No.
Patients struggle a lot.
Big problem. Yes, that's so true. I often say once a patient starts a benzodiazepine, they never stop a benzodiazepine. So you have to be careful with your prescriptions.
It's been a couple decades since I finished residency, but I remember even back in residency, we talked about how we rarely started people on benzos. Well, of course, we continued many patients on it, but we rarely started it. And I completely agree with you. I rarely start a new patient on a benzo because we know what happens. It's hard to get people off, And so we try so hard to avoid it in the first place, but many patients obviously use it a lot.
Well, the problem is the darn things are so effective. I mean, it's like stimulants for ADHD. I'd rather not prescribe a stimulant, but they're so darned effective.
Right.
So sometimes we do have to do it. Yeah,
absolutely.
Well, I find that fascinating. Is there any preliminary evidence at all at this point?
No,
for
zero,
CBD for
none.
benzos? Oh, right. Wow.
Benzo withdrawal management, benzo, use disorder management. I mean, there is a huge, scientific literature gap. Very few people focus on that area, and it's hugely neglected. It's really unfortunate.
Yeah. I guess the closest thing, of course, would be alcohol, which also works on GABA A receptors. It's sort of similar, but not the same, of course.
Yeah, there's a couple of trials that are, I believe, completed out of NYU. And they looked at cannabidiol for alcohol use disorder, as well as the comorbidity between AUD and PTSD. And they haven't published their reports, but it's been a while since they've completed. I don't know the ultimate outcome for them, but we're waiting to hear to find out.
Yeah, certainly. Boy, we certainly need anything that helps with PTSD, that's for sure.
Yeah, for sure.
And I'm sure part of what you do clinically is aggressively managing any comorbid psychiatric conditions, depression, bipolar, and so on, anxiety.
And so
I would think.
Yeah, and CBD could play a role in it. As we sort of alluded to earlier, it potentially has antidepressant, antipsychotic, and of course anxiety and sleep. And so it could be a nice, if effective, it could be a really nice treatment for many of our patients who suffer from so many of these comorbidities and the trauma piece too. So, it kind of hits all the main categories of comorbid conditions. And so it'd be nice if the medication kind of targeted some or many of them.
Yeah, it certainly is fascinating. And I really want to compliment you on this work so far. Do you think that there is enough evidence here? I'm just thinking of our audience who are mostly clinicians. Is there enough evidence here for them to maybe start recommending this for their patients or starting to think about somehow integrating this into the practice?
So I get asked that, and I'm not sure because again, Epidiolex at this dose is really not available. And if you go to a dispensary, it's buying the whole bottle basically for a single day dose, and that's really not financially possible for most people. And I don't recommend that. And so then the question that becomes, is 15 milligrams enough? And I don't have a good answer to that. I don't think it is.
Yes.
I mentioned the cannabis study. So, CBD appears to attenuate cannabis use in those with cannabis use disorder. I believe they removed the lower 200 milligram dose because it was not effective. Meaning, again, for therapeutic indications, there's a strong suggestion that you really need to, attain these much higher dose ranges. And I don't think 10 milligrams a day is really going to do it. And so I don't have a good answer. If you take 10 milligrams a day and you find it helpful, I'm not going to discourage you from doing it. But if you're targeting things that we're talking about here, things like OUD or cue reactivity, you're probably having to look at much, much higher dose ranges. And that's not easily accessible to patients, unfortunately.
Yeah. So it sounds like at least 400 milligrams is what you're saying. Ideally, even higher.
Yeah. That's a hefty dose.
There might be some patients out there who have the means. Perhaps for some patients who can afford it, it's possible.
So I do check for these, companies who make, CBD products, and some of the highest dose ranges now appearing are much higher. So I think there may be a company that produces like 100 milligram CBD capsule. And so that's approaching the kind of dosages that we're talking about. And so as some of these companies begin to produce more higher dose ranges, it may become more feasible and more financially, less problematic, but we're not there yet.
What about marijuana, though? What about people using marijuana to get CBD or other cannabinoids to maybe help with their opioid use? I realize it won't help with their cannabis use disorder, but do you think that's a reasonable thing to consider?
Yeah, I think the evidence is mixed. And so over the years, there's been many studies looking at both buprenorphine and methadone outcomes, comparing those who do and do not use cannabis. But for obvious reasons, it's hard to evaluate those because, if you're using cannabis, what does that actually mean? How much? What type? THC constituent? Are you vaping? Are you smoking? Are you edible? So it's all over the map. And so that has led to, there's been newer studies looking at if people use cannabis products, do they do better on buprenorphine or methadone? And the answer is, we don't know because it's completely mixed. Some studies show positive findings. In fact, others show completely negative. But if you look at across the board, it really doesn't seem to be any robust effect one way or the other. So that's in a way the good news is that those who use cannabis is not harmed by it.
I see.
And it's not going to impact your outcomes from buprenorphine or methadone. But on the other hand, it does not seem to have a robust effect in improving outcomes dramatically. And so the jury's out if it's doing much, if anything at all.
Yeah. Well, it's also very hard to study because marijuana has so many cannabinoids in it.
Correct.
There's, I believe hundreds of them. So it's really hard to tell what's going on.
Correct. And so hopefully
both pharmacodynamically and pharmacokinetically, there is evidence that there are some drug interactions that can be interference with some of the cytochrome P450 enzymes.
Oh yeah.
So we have to be careful.
It's a very complicated pharmacology. And so it's really hard to know what to recommend. Right. So I don't, what the message I give to patients is that if they're willing to be on buprenorphine and methadone for OUD, then that's the most important thing. And it'll work. The good news is it'll work whether you're using cocaine, cannabis, alcohol, benzos, you have chronic pain, you're depressed, you're anxious. None of those things will matter in the sense that buprenorphine or methadone are still effective. And for me, that's the most important message.
Got it. Well, there's even abundant evidence of buprenorphine's antidepressant activity. There was a form being studied for depression at one time. In addition to its mu partial agonism, it's a kappa opioid antagonist, which is gaining a lot of attention.
Oh, yeah. And so folks at our MGH were doing those studies, samidorphan and buprenorphine.
Exactly. Yes, I did those studies too.
Those came out to be negative largely. So Alkermes has abandoned, producing them as a potential novel, antidepressant. Yeah. But you're right. That's another interesting avenue in terms of targeting the kappa, kappa system. Yeah.
Well, there actually were positive data, but they had a lot of methodologic issues, let's just say, and the FDA had some issues.
So we just did publish a, review paper looking at low-dose buprenorphine as a potential treatment for anxiety and depression. And so, so you're right. Buprenorphine has some interesting properties that could be applied to other indications.
Yeah. Well, there's a long literature of buprenorphine by itself as an antidepressant. It's quite effective, but there's always the mu issues, right?
Absolutely.
Right. Well, I have to tell you how much I really enjoyed our conversation, Joji. I appreciate your time. You clearly have thought a lot about this, and I commend you on the work you're doing. It is a huge public health issue. I'd just like to ask, is there anything else you'd like to leave our audience with? Any other tidbits or any other thoughts about where we're going here in this field?
Well, we are in desperate need of innovative treatments for OUD, both pharmacologic and psychosocial, and the struggle continues. It is getting worse out there, and it's heartbreaking in terms of the impact it has on people and communities. And so we need innovation in addiction treatment across the board. It's not just for opioids too. It's alcohol, deaths are rising, stimulants, etc. And in some sense, we're lucky with opioids. We have some effective therapies. But once you step out of that, we have some for alcohol, but beyond that, we have virtually nothing. And so we are in desperate need of innovative treatments. And it could be cannabinoids. It could be GLP-1 receptor agonists. It could be psychedelics.
Yes, we didn't talk about that.
And we're hoping to do all kinds of things. So we have a lot on our plate in terms of innovative therapies we're investigating.
Yes, well, we have to talk some other time, Joji, about the GLP-1 agonists. I'm really fascinated by those. My very good friend Roger McIntyre in Toronto is studying them for depression and bipolar, and there is this preliminary evidence on decreasing craving. The idea of repurposing is fascinating to me.
Absolutely. Yeah. So we have our grant currently under review to do a pilot RCT of semaglutide for OUD. So keeping my fingers crossed. Get to do that.
Stay tuned. You're a tease, Joji. That's a great tease. Yeah. Well, with that, I want to thank you, our audience, for listening. And please go to our website or go to wherever you get podcasts for our many other podcast options. And our website is neiglobal.com. Thank you so much for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.